Welcome to Breast Cancer Awareness Month. We're so very excited to be presenting a series of webinars that will address some of the issues, questions, and concerns patients have about screening for breast cancer, treatment for breast cancer, and research that's currently available. Today is the first of the 4 webinars entitled Breast Cancer Screening, Methods and Myths. This amazing webinar series is generously sponsored by the Irene Dunn Guild, along with the Ken Johnson family in memory of Joan Brierton Johnson. I am your moderator today. I'm Janie Grumley. I'm the director of the Comprehensive Breast Program at the Margie Petersen Breast Center and the John Wayne Cancer Institute. I'm very, very excited to be introducing our speaker for today, Dr. Crystal Fancher, who is a surgical breast oncologist who recently joined the Margie Petersen Breast Center and the John Wayne Cancer Institute. Dr. Fancher is a Los Angeles native. She was in fact actually born at St. John's. She did her undergraduate work at the University of California in Davis. She actually earned her degree there in genetics, then went on to do a master's degree in physiology from the University of Cincinnati. She continued with her medical education at the Medical University of Southern Carolina College of Medicine, and then went on to do her residency at Mercer University Navicent Health. She more recently completed her breast fellowship program at University of Southern California Hoag Memorial Hospital fellowship program, and joins us now as our newest breast surgical oncologist. We're very excited to have her join our team, and we're looking forward to her presentation today. At any time, if you feel like your questions are not being answered, feel free to contact us at the Margie Petersen Breast Center. Our main line is 310-582-7100, or you can connect with us via email, breast@providence.org, or through our website at www.stjohnscancer.org/breast. We hope you'll enjoy this webinar.
Good afternoon, everyone, and thank you for joining us for our webinar, Breast Cancer Screening, Methods and Myths. I'm Dr. Crystal Fancher. I'm one of the breast surgical oncologists at the Margie Petersen Breast Center at Providence Saint John's Health Center, along with the John Wayne Cancer Institute. Today, we're going to be talking about breast cancer screening, about the different methods, and hopefully dispel some of the myths that you may be hearing. Let's start talking about mammograms. So in the news media and all over the internet, I'm sure you can see so many different articles about different recommendations for mammography guidelines. The question is, why does it vary so much? Why isn't there one obvious answer? And the truth is that everybody's looking at things from a different perspective. When you look at things from a different perspective, you're going to get a different answer. So let's talk about guidelines for screening mammograms. So most groups will agree that over the age of 50, you should definitely be getting your mammogram. Where the controversy lies is in the average risk woman who's aged 40 to 49. You can see here is a list of multiple different organizations that are highly respected. However, all have varying ideas about when to start screening and how often. You can see that it ranges from the individual decision to starting at age 45 with the option to start at age 40 to multiple other places recommending definitely starting annual screening mammograms and clinical exams at age 40. So why is there such a discrepancy? It leaves everybody sitting there questioning, well, which one do I look at and how do I choose what's right for me? So the United States Preventative Services Task Force recommendations were based on an imperfect data. This was population studies, and a large portion of the screened patients were not screened appropriately, and some patients in the no screening group even went outside the study and got screened. So the data here really isn't exact. What we do know is that breast cancer mortality is reduced with mammography screening. And higher stage tumors are also reduced with screening for women aged 50 years and older. Why the USPSTF decided to recommend screening over the age of 50 was because they found that there were false positive results. However, They were common in all groups. They did see these more frequently in younger women and those with risk factors. The concern was that there was up to 22% of cases that may be overdiagnosed. Observational studies, however, show that things like tomosynthesis, which we'll get to, with mammography reduces recalls but increase the number of biopsies and cancer detection because of it. So mammography screening at any age really is a trade-off and a continuum of benefits and harm. So let's talk about how we can start to decide how to deal with this. So let's talk about some of the benefits. From age 30 to 49, there's an absolute mortality reduction of 4 per 10,000. And of course, it increases over age. We're up to 5 to 8 per 10,000 in the age 50 to 59 group, increasing to up to 21 per 10,000 in the 60 to 69 group, and over 70, the sample size was too small. However, we do know that higher stage tumors are also reduced with screening for women over age 50, and for younger women with dense breasts who have an annual mammogram compared to the biennial screening. So what's the harm? So false positive rates and recommendations for additional imaging were highest in this controversial group, that women who were aged 40 to 49, and did decline with age. But the false negative rates were low across all groups. And the rates of recommendations for biopsy didn't differ between ages. So the concern really is overdiagnosis could lead to overtreatment, and that the false positive results could lead to severe patient anxiety, causing hysteria. So we have to weigh the risks and benefits. On the benefit side, we have a mortality reduction of 4 in 10,000. We have reduced cancer stage at diagnosis, and we have reduced treatments when caught at an early stage. On the risk side, we have false positive rates, risk of anxiety, overdiagnosis, and overtreatment. So how can we tip the scales in the favor of the patient? Here's an image of varying densities of breast tissue. When a breast cancer is detected on a mammogram, it looks white. You can see as you go from A to D of more dense breasts being D, it can be more difficult to find an area of white that could be a cancer in a very dense breast. So the way that we alleviate these false positives is with choosing the right study for our patients. We have something called tomosynthesis, or 3D mammogram, which is able to take multiple thin-cut images of the breast. This helps us to decipher between disease and dense tissue. In the image on the right, you can see that the tube is actually able to rotate, which allows X-rays to be taken from multiple angles. Here you can see a 2D mammogram versus a 3D mammogram. On the left-hand side, you can see how it may be difficult to see exactly where this cancer is in all of that white that you see in the breast. On the right-hand side, in the 3D mammogram, it's much clearer to see that there really is a cancer in that area that requires further biopsy. Now, don't freak out. This whole idea here is to decrease the false negative rate, which means that we don't want to send you home after your 2D mammogram and tell you everything's okay when it's not. And we also want to decrease the false positive rate, which means that we don't want to tell you that there's a cancer and it turns out that there isn't. So the idea here is really to hopefully decrease all of that anxiety with our better imaging technologies. What you have to understand is that no woman is alike. Everyone is different, and we really have to tailor not only the treatment of breast cancer, but the screening of breast cancer to different types of patients. And I think that's very well exemplified in the cosmetic industry. They've done such a good job of making sure that they tailor their cosmetics to each and every woman, because again, not everybody is the same. I want to talk a little bit about how mammograms work. So you can see by this screen, everyone I hope has looked for Waldo at one point in their life. But you can see by this image, you're looking for Waldo in a sea of things that may also look like Waldo. So what if that was Waldo? Or this one? Is he over here? Is he over here? It's hard to tell. So sometimes when you get your 2D mammogram, or even sometimes your 3D mammogram, we can see a few things that may look like Waldo. And in order to clarify and see whether it really is Waldo or a cancer, we sometimes have you come back for additional views. This would be a mammogram callback. At that point, we're able to magnify these specific areas that looked concerning and really find out whether this is something we need to be concerned about. You can see here, there's Waldo, but we also thought maybe this was Waldo. Now we can clearly see it's not. Again, clearly not Waldo here. And again, clearly not Waldo here. So the idea is that at least 10% or about 10% of women who have a mammogram will be called back. That doesn't mean that you have a breast cancer. It just means that there's something that was seen on your mammogram that needs a better look. Now, 8 to 10% of those women will need a biopsy. But the good news is that 80% of those biopsies turn out to be benign. And this means that less than 10% of the women who are called back for more tests are actually diagnosed with breast cancer. So what that means is, even if you get a call back, your chances of finding of it being a breast cancer are very low. So I think we need to learn to understand why women are being called back. And hopefully this can help to decrease the anxiety that women have when they're asked to come back for additional imaging or testing. So what do we know about mammograms? So mammograms save lives. They do have their limitations, and we have to choose the right study. Breast cancers that are found early have different treatment options than those that are found at a later stage. And there is such thing as overdiagnosis and overtreatment, and not all cancers are the same, and not all of them should be treated the same. So I think the final message there is definitely discuss with your doctor about recommendations for screening and what the right test might be for you. Now, we've talked a lot about mammograms, but what about other things? I know you guys have heard about different types of imaging for the breast that's not just a mammogram. I'm sure you've heard about MRIs, about ultrasounds. There's different types of automated breast ultrasounds out there, such as ABUS and Sonocine, as well as even things like thermography. So what are these, and are these helpful, and can they replace your mammogram? None of these can replace your mammogram. Your mammogram is still the gold standard for breast cancer screening. Let's start with MRI. Again, not used for screening, it's used in addition to your mammogram. So an MRI, you are laid on your stomach, face down, your breasts are placed on a special plate so that they hang down, and you get an IV, and a special dye is injected into your veins to be able to see better the breast tissue. What we're looking at on an MRI is actually blood flow in the breast. On the right-hand side of this image, you can see that there is a large tumor with large blood vessels leading to the tumor. On the left, there's also blood vessels. As we know, the breast tissue does have blood vessels in it, but they're certainly not as prominent, and there's no obvious large mass. These are the things we're looking for on MRI. So how do we use the MRI? It may be used if you have an increased risk of breast cancer above the average risk. This includes patients with known genetic mutations, such as BRCA1 and BRCA2. It may also be used after a breast cancer diagnosis. This helps us to get a more detailed look at your breast to help with both surgical and treatment planning. Helps us measure the site of the breast cancer, look for other tumors in the breast, and check for tumors in the opposite breast. However, not every woman with breast cancer needs an MRI. MRIs may find more lesions that are not cancer and lead to more biopsies. So we do recommend MRIs with caution, understanding that it will find more things that are not likely to be cancer. So with MRI, it uses strong magnets, but no radiation. So if you have any metal in your body, you may not be eligible for a breast MRI. Some metallic objects cause problems and some do not, so make sure to check with your radiologist and technologist prior to an MRI. Next is ultrasound. Most of the time, this is done handheld. Again, not used for screening for breast cancer, but in addition to your mammogram. Here's a picture of a woman getting a breast ultrasound. You can see the images are displayed up on the machine, and the transducer is held by the technologist on the breast. This delivers sound waves into the breast to create a picture of inside your breast. Here's an example of what an ultrasound looks like. This is mostly used to look further at any area of concern seen on a mammogram. So sometimes when you're called back, we will ask for an ultrasound as well to get a better look at an area of the breast that may have shown up on a mammogram. Sometimes they can help us tell the difference if it's a fluid-filled cyst, which is unlikely cancer, or a more solid mass, which may require a biopsy or further testing to determine if this is a cancer. One of the things I point out is that an ultrasound cannot see calcifications. This is one of the reasons why mammogram is still used as the gold standard for breast cancer screening. Many times early stage breast cancer or stage 0 breast cancer, known as DCIS or ductal carcinoma in situ, can be seen simply as calcifications on the mammogram. Many times this is the first sign that there's a non-invasive cancer present. Again, this is why we use mammogram over ultrasound for screening, and why we use ultrasound in addition to our mammogram if needed. Ultrasound may also be used to obtain a biopsy if we do find something that's concerning, or in surgical planning. Again, this uses sound waves to make a picture of the inside of your breast, and there's no radiation associated with ultrasound. There have been some advances in whole breast ultrasound where there are many places that are coming out trying to create a way to look at the whole breast in an easier fashion than simply using the handheld ultrasound. There's something called the ABIS, or automated breast ultrasound. This uses 3D ultrasound technology and takes about 15 minutes. Other options that may be out there are something called the sonocine. This is an ultrasound that's recorded as a video instead of as single pictures, and this can be done in less than 30 minutes. I caution you again, all of these may be used in addition to your mammogram, but do not replace your mammogram for screening. Here's an image of what the ABIS looks like. It creates multiple images of the whole breast in a three-dimensional picture. And here's an example of what a breast ultrasound looks like. Again, this would be played as a video as the probe scans through the breast tissue. Something else you may have heard of is called thermography. Again, not used for screening, but used in addition to your mammogram if desired. This is an example of what a thermography looks like. The idea here is that it's a special procedure with a camera that can sense different heat levels and is used to record the temperature of the skin that covers the breasts. The idea here is that tumors may cause temperature changes that would show up on the thermogram. I emphasize may. There have been no randomized clinical trials of thermography to find out how well it detects breast cancers or the harms of the procedure. Thermography is not sufficiently sensitive to be used as a screening test for breast cancer, nor can it be useful as an indicator for your risk of developing breast cancer within 5 years. There's no sufficient evidence to support the use of thermography in breast cancer screening. Again, if it's something that you're interested in, it can be used in addition to your mammogram. So, putting it all together. On the left, we have screening for breast cancer. Mammogram is the gold standard. This is what we recommend, 2D or 3D. Again, our recommendations would be to start at age 40, but talk to your doctor about when to start with your screening mammogram, and also about what additional options may be needed for you based on your risk and your breast density. In addition to your mammogram, we talked about ultrasound, which could be handheld, the ABIS or the sonocine, MRI, and thermography. So now I wanted to go through a few myths and facts that I'm sure some of you have heard. I think one of the first and the biggest ones I always hear is, I don't have any family history of breast cancer, so I don't have to be screened. This is not true. 85% of women with breast cancer have no prior family history. This means it's important for women over the age of 40 to have annual screening mammograms. And early detection is the key, as early stage breast cancer has a 5-year survival rate of 99%. Next, mammograms have unsafe levels of radiation. Not true. We did talk about a bunch of other ways to look at your breast, such as ultrasound, MRI, thermography. All of these don't use any radiation. However, mammograms do use a small level of radiation. There is radiation use, but again, very small. A typical mammogram with 2 views is about 0.4 millisieverts, which is a measure of radiation dosage. The average radiation exposure from a woman that she gets just from her surroundings, which is called background radiation, is about 3 millisieverts a year. This means that 1 mammogram is equal to about the natural radiation a woman would receive over approximately 7 weeks. So again, very low doses of radiation when you weigh the benefits of detecting an early breast cancer. Next, 3D mammogram is the same as the traditional mammogram. It's not. We talked a little bit about this, but the tomosynthesis or 3D mammography is able to display more images of the breast in thin sections of the tissue. This means that it's able to increase early detection of breast cancer and can be helpful in patients with dense breast tissue. Oh, this is another one I hear. I've lived this long without getting breast cancer. I don't need to bother with a mammogram now. Not true. Your risk of getting breast cancer increases as you get older. This means that most breast cancer is diagnosed over the age of 55. So even if you've been through menopause, you still need your mammogram. Finally, and I hope this is the point I've driven home, is if I get called back, I have to worry that I have cancer. No. Again, 10% of women who have a mammogram will be called back. This means that for every 10 mammograms you have in your lifetime, you're likely to get called back for additional screening once. But again, only 10% of those 10%, only 10% need a biopsy, which means, and 80% of those biopsies are benign and not a cancer. This means that less than 10% of the women who are called back for more tests are diagnosed with breast cancer. I hope this helps you understand why we call patients back, why we need additional imaging, and hopes to alleviate some of the anxiety and stress that surrounds getting your mammogram. Again, as a final point, we definitely recommend your screening mammogram. There's nothing out there that replaces it, but there are many things that we're able to do in addition to it to help enhance our screening for breast cancer. It's time for questions. We'll be happy to take them at this time. Thank you.
Thank you so much, Crystal, for that very nice review. We do have a few questions that have been typed in, and if you would like to add your questions now, feel free to do that in your question box down below. We'll start with our first question. Crystal, if you want to answer it, the question is, of my 3 sisters, 2 of them have been diagnosed with HER2-positive breast cancer. We do not carry the gene. Do we need to do anything different with my annual breast cancer screening? Should I go every 6 months instead?
That's a great question. So with that significant family history, there's a good chance that your lifetime risk of breast cancer could be elevated above 20%. We have some great tools like the Tyrer-Cuzick that can calculate your risk of breast cancer. And if you are over 20%, then you could consider adding an MRI to your annual screening. And some people like to stagger those every 6 months. So you would do your annual mammogram, 6 months later do an MRI, and 6 months later back to your mammogram. So I think definitely talk to your physician, and they can look into if that would be something you would qualify for.
Other things to think about too is how old were your sisters when they developed breast cancer? There are some age-related risks, and that may play a part, like Dr. Fancher said, it will play a role in the calculators that we can use to decide what your risk might be, and then go from there. The second question we have is, how long does it take to get a mammogram? Is it a short visit? I can answer that one because I got my mammogram this morning. It is October. So I went and got my mammogram this morning. It took us probably about 15, 20 minutes. Obviously, there's some paperwork ahead of time. Just keep in mind that if you come for your mammogram, one of the first things they're going to ask you is if you're having any symptoms. If you are having symptoms, it would not be appropriate to have a screening mammogram. And so they will often tell you to go and see your primary care doctor, or you can actually, if you have it done here at the Margie Petersen Breast Center, be seen by our nurse practitioner right away. It's not appropriate to get a screening study if you have any lumps, bumps, pain, discharge, anything like that, because that's a different type of workup. But for a screening mammogram, it typically takes them about 20 minutes to get you in and out. There are 4 kind of positions that you'll be placed in, 2 on each breast. The actual compression time is probably only about 20 seconds, if not less. So it's a lot of positioning, getting you in the right place, getting you set up for the actual picture, but the picture itself takes only about 20 seconds each. Our third question, you spoke about breast density. What does it mean to have dense breasts? Dr. Fancher?
Sure. So the breast is composed of breast tissue and fat, and it's really the amount of breast tissue that you have in relation to the amount of fat in your breasts. As you age, the ratio changes, so you have more fat and less dense tissue. Some women, though, however, throughout their lifetime, still have what looks like more breast tissue than fat ratio. It's really the way that they appear on imaging, so it's not something that you would really know just from the way that they look or feel. And you can find this out, again, once you've had your imaging done. They can let you know whether your breasts are on the denser side. But again, as you age, they tend to get less dense, which is why we don't recommend mammograms for very young women if you're under the age of 30.
We have another question that asks, are there any special offers for Breast Cancer Awareness Month for 3D imaging specifically? I'm guessing this is in reference to cost of a 3D mammogram versus a 2D mammogram. It is very unlikely for insurance companies not to cover a 3D mammogram nowadays. There are some centers, and this was more historical, maybe a few years ago, where some insurances will not pay, and you are asked to pay a copay for a 3D mammogram. I rarely hear that nowadays. A lot of that largely depends on the type of insurance you have, but 3D mammogram is very much accepted as a standard of care. So there should not be any additional costs for most people, but again, if there is, it's likely because of your insurance company and not because of your imaging center. So you may want to look into that or have them look into it for you before you arrive for your screening mammogram. Another great question here. When can we stop getting mammograms? Dr. Fancher?
Sure. So really the answer is when you think your life expectancy is less than 10 years. So I've certainly seen women nowadays are living longer and healthier lives, and we're starting to see patients that are very active into their 70s and 80s. And so if you are one of those women, then there's no reason to stop getting your mammogram. I think that it used to be thought that if you were over 70 or 75, that maybe you didn't need your mammogram anymore. But again, we're seeing women who are being diagnosed in their 80s who still have a good 10 years life expectancy. So it's kind of up to your doctor and how well you're doing at that age, but there's not an exact number.
I know as 70 gets closer to as I get closer to 70, I feel like that's younger every single day. Our next question. I've been doing 2D mammograms and my doctor found a very small calcification. Because it's so small, they are having me come back every 6 months. Do you recommend doing a 3D mammogram? Will they help? If so, what else do you recommend? Any thoughts?
So usually if you find calcifications like that, if they're so small, then they're probably not concerned enough to biopsy them. They're just wanting to watch it. If you have access to a 3D mammogram for your next mammogram, that's always helpful. But really the 3D mammograms help us to find masses that may be hidden within dense breast tissue, not necessarily the calcifications. So I think if they're following a calcification, they're doing a great job. I don't think that there's really anything else that I would recommend right now. Just make sure you keep up with going back and let your doctor know immediately if you start to feel a mass or note any other changes in your breast.
Yeah, and the reason for a 6-month follow-up is not so much that they see the calcifications. I think most situations they're trying to see if there are more calcifications in 6 months. So it's that change they're looking for, because if you find something, it doesn't mean that it's growing or changing. You need that second time period in order to compare it. So it's like if I get on the scale just once, I won't know if I'm gaining weight or losing weight. I kind of need that 6 month to kind of see where we're at. And so that's what the mammogram in 6 months will help us determine. And so it's a good idea to get it. Then we can determine if that one calcification they found is stable. That means it's not changing, it's not increasing in numbers. Then that would be considered a benign finding. All right, we have a few more questions yet. So I have dense breasts, and every time I go in for a mammogram, after completed, I'm asked to come back in 6 months. Why is that?
So my guess is that they see something on your mammogram that is of low concern, but something that's not completely normal. If you had a completely clear mammogram, then usually it would be that you would come back in a year. If they see something, and that can be something just the way that the tissue had folded, or they do see a small dots of calcifications that they want to watch, they're probably, again, looking at something that they want to look at another time point, like Dr. Grumley pointed out. So I can't comment exactly what they're looking at, but those would be my guesses. There's either some sort of density or some calcifications that they're watching.
And that would be definitely a good situation to make sure that it is a 3D mammogram. Some people will even want to add the ABUS to that. I don't know if you said that, but all right, it looks like we got an answer. So the first question that we got was 2 sisters with HER2 positive breast cancer. It looks like they were both diagnosed at 36 and now 70. Mom had breast cancer at 50 and died. So the person that's asking is near 70, so at the age of 69, and hasn't gotten breast cancer yet. So what do you recommend for someone like this?
Again, I think that they certainly, it's hard to calculate off the top of my head what their lifetime risk would be. It's a pretty extensive algorithm, but just looking at this, it does seem like your risk is probably over the 20%. Mm-hmm. I would think that you can certainly see if you would be eligible for an MRI between your mammograms. Some people do them and they don't have any problems with them. It does require that you lay down on your stomach. Some women have a difficulty with that as they start to get older, climbing up onto the machine. And it does require that you get an IV and get an injection of a special dye so that we can look at the blood flow. So those are all things to consider. You know, I'm assuming you're pretty young and healthy at 69 and pretty active still. So I think your life expectancy is probably over that 10 years. And I think that getting an MRI would not be a bad idea. I don't think that you necessarily would need an MRI every single year, but it might be something to get a good look at your breast, maybe follow it a couple of times, and then consider spacing it out every few years.
Yeah, I would agree with everything you said. If you're concerned at all, you're more than welcome to come into the Margie Petersen Breast Center. Tara, our nurse practitioner, has what we call a high-risk clinic, and it's fantastic. She can actually sit there and calculate your risk based on the calculator like Dr. Fancher was talking about. We can also pull up your mammogram and look at what it looks like. If you have predominantly fatty breasts, an MRI is probably going to not add a whole lot of information to your breast cancer screening, but if you do have fairly dense breast tissue, that may be the tool that we need to add and help you design what is the right screening plan for you. I think that's what we're really trying to drive home. Sometimes it's hard to fit people into algorithms and always follow algorithms and say that one size fits all. In situations like this, I think it's best to kind of tailor your screening to what your needs actually are. Our next question, is it safe to get a mammogram during the pandemic?
Yes, definitely. Everybody that comes into the Margie Petersen Breast Center has their temperature checked at the door. We're all wearing our masks, and I think it's definitely, we don't want to be missing breast cancers now. Definitely come in, get your mammogram, get screened. make sure that you're not putting it off, because what we really tried to drive home is that if we find breast cancers early, then there's a multitude of available treatments and a good chance for cure. So don't put it off. It's absolutely safe to come in and get your mammogram.
Absolutely. If nothing else, this pandemic has probably taught all of us that health is super important. Without our health, everything kind of falls by the wayside. So do not delay screening if it's time for your screening. Do not delay imaging if you feel something. So it's not just screening. Unfortunately, during the pandemic, I have heard multiple stories of patients saying, oh, I felt something at the beginning of the pandemic and then I was too scared to come in. And unfortunately, by the time we do the workup, things were definitely a little bit different. Some people it will be different, some people it won't. I'm not trying to scare anybody, but just wanted to make sure that people understand that it is absolutely safe to come in. We're taking every precaution to keep all of our patients safe. A couple more questions yet. I've had to get an ultrasound every mammogram due to a cyst. At what point do I need to get it removed? It scares me every year.
So cysts are benign. The reason that we have you get an ultrasound after your mammogram is to look at that area a little bit differently. Cysts can show up better on ultrasound than on mammogram. Clearly they were able to see it on your mammogram, but we're able to better investigate it with ultrasound. Again, cysts are benign. They don't turn into cancer if that's really what they are. The reason that we watch them is we want to make sure that it truly is a cyst and it's not something that is changing. There's no need to get it removed. Usually after about 2 years of stability, as long as they don't see any changes on your mammogram, they won't continue with the ultrasounds.
Another question. I have dense breasts and have to get the mammogram and ultrasound. Can I schedule them both on the same day or wait to do the other appointment at a different visit? So at the Margie Petersen Breast Center, you can actually get both of those scheduled. And I know there's a lot of imaging centers out there that will help you coordinate both of those studies. And I'm assuming this is for screening. So there are different ways, like Dr. Fancher had talked about, to screen your breast. You can do a complete breast ultrasound, which is a handheld ultrasound that's limited by the technician. So you have to go to a center with a very skilled technician, or what's called a screening ultrasound, or ABUS, automated screening breast ultrasound. That is available at Tower Imaging. So you can get both the screening mammogram and your ABUS at the same time. You just have to let the scheduler know when you call in to schedule that that's what you'd like to do. No reason to do it on different days. All right. My first mammogram 5 years ago at 50 years old said I had dense breasts. I'm going back for the first time October 20th. Can I request a 3D mammogram beforehand?
Yes, you can. We have the tomosynthesis machines here, and absolutely something that you can get.
Yeah, and it's pretty easy. In fact, in some places it's pretty hard to get a 2D now. One day those 2D machines will probably be mostly aged out, but it should be very easy to get. It should be easier to get your 3D mammogram than a 2D.
Yes.
Do radiologists let you know if you have dense breasts?
They do. Sometimes they'll talk to you at the time of your mammogram, and it usually is listed on your mammography reports whether your breasts are dense or not.
Yeah, so they're actually mandated on your report to report that. You can ask your primary care physician too if you don't know where to look. It's going to be on all of your reports for your mammogram. To add to my question about the cyst, it has been there at least 10 years and is painful when I hug too tightly or too much. Caffeine always says it looks okay, but keeps an eye on it. So that lady who had that cyst.
Again, most of these cysts, it's not going to turn into something. Sometimes if it is extremely painful, you can talk about getting it aspirated, but many times the cysts can come back even after aspiration. Sometimes this does give women relief to consider aspiration. Again, I don't know how large it is. Sometimes they're very, very small and aspiration's not an option.
But if it does bother you, surgery is always an option. I mean, we used to surgically remove all of these cysts, but then that subjected a lot of women to unnecessary operations. But if it's something where you feel like it's either getting bigger, it is painful, and you're tired of looking at it, what you want to do surgically is a very small operation. It's an outpatient procedure. You do not have to stay overnight in the hospital, small incision. What you want to do, though, is remove the entire cyst wall so that it doesn't have a chance to come back. But that is an option if it bothers you enough, just to keep that in mind. But most women would rather not have surgery if they don't need it.
Right.
And this is not needed unless you do have significant symptoms. Since my breasts are dense, why can't I skip the mammogram and just do the ultrasound? I've always been told they can't see anything on the mammogram. Sorry if I missed your coverage on this in the beginning.
Not a problem. So the reason that we do the mammogram is the mammogram can see calcifications, which the ultrasound cannot. Many times early stage breast cancer or early breast cancer known as ductal carcinoma in situ, or you may hear it called DCIS, it shows up on your mammogram as just a few calcifications, and that's the earliest way we can catch breast cancer. So even though you do have dense breasts and we know that it might be difficult to see a small mass, which is why they add the ultrasound for you, it's still important to get the mammogram because it can see the calcifications that we're not going to be able to see on the ultrasound.
Yeah, so still important to get that mammogram as much as we hate it. Definitely want to get a 3D versus a 2D if it's very dense, but it does find those little darn calcifications that we can't see in a lot of the other studies. This has been very helpful. Thank you, doctors, for taking your valuable time. Great. I am so glad we were able to do this.
Absolutely.
Please feel free. What are your thoughts on coffee and cysts? I recently decreased coffee intake.
Ooh.
Our favorite topic, breast pain.
It's so hard, and there's really no good randomized controlled trials on this. There's no obvious evidence. There's just kind of anecdotal evidence. I think in some women who are drinking a lot of caffeine, some of them say it helps, some of them say it doesn't. If your cyst is really bothersome and you're okay cutting out that morning cup of coffee, then by all means go ahead. If it helps, great. Although there's really no specific data that says that it is helpful. Some women have said that they've seen benefits, others don't.
Yeah, I think it's very individual, but there's no harm in trying.
Right.
You might get a headache from not having caffeine, but there's no harm in trying it because if it works, that's a great way to decrease your pain. But just keep in mind that caffeine's also in other drinks, right? Caffeinated soft drinks or teas. I've had patients tell me, I cut out coffee completely. I just drink black tea now. Well, that doesn't really eliminate your caffeine intake. So it's all caffeines. But it's definitely worth a try. And if that does help, obviously that's a better way than doing surgery. Sometimes a couple aspirations will do it as well and help relieve some of that discomfort. But speaking of breast pain, what are some non-cancerous causes of breast pain? I was seen at a high-risk clinic, strong family history of BRCA, and was told my intermittent breast pain was possibly caused by stress.
So it can be. So some of the non-cancerous causes of breast pain, so being near your period, so hormonal fluctuations, if you're premenopausal, can certainly cause increased sensitivity in the breast and breast pain. If you do have a cyst, sometimes that can cause women pain. Some people have a small mass that's called a fibroadenoma, which is not a breast cancer, but sometimes can cause discomfort in the breast. Again, stress as well. I think that really changes with your hormones, and that can cause some of the breast pain that you might be having. We don't know exactly what causes all women's breast pain, and some people have very mild breast pain occasionally. Some women have none, and some women have very debilitating breast pain. So we don't have a perfect answer, but it's definitely a combination of things that can cause breast pain.
Yeah. And I think that's why it's so hard for us to fix breast pain, because it's often different causes. Hormones, if you're on any hormonal medications, can cause changes to your breasts. One thing to think about, though, very painful, sudden onset pain can be infections. So that's something that you will definitely want to seek medical care for if you suddenly have breast pain. Things people don't necessarily think about is a bad fitting bra can also cause breast pain. So make sure you're well fitted for your bras. I've heard patients come in with breast pain and you kind of dive into their history and they'll say, oh yeah, I changed to this other type of bra or something. The way it fits can change how your breasts feel. So lots of different causes, but in general, stress can definitely be one of the causes, although sometimes I feel like we just say stress when we don't really know. And that may be part of it too, is that we don't really truly understand why some people's breasts hurt and some don't. And it may just be your own fluctuation of hormonal levels that aren't well detected. We are more than happy to answer questions. You can connect with us either at the Margie Petersen Breast Center, and I think we put up some of our contact information at the beginning of this webinar. Feel free to reach out to us, or if you just aren't sure about what you should do for screening, feel free to call the office. And like I said, Tara, our nurse practitioner, has what we call the urgent care clinic for breast. She can definitely get you in and sort things out for you, or we'd be happy to answer any other questions you might have. You can connect with us.
Absolutely. Thank you so much for joining us and really appreciate you guys taking the time.